these people too, I went one too soon. So my dad stayed at home still. He had live-in. When he was with my mother, he was taking care of her, though the family myth was that she took care of him. And he was making sure she ate, and she had the eyesight so she could help him look up a phone number and things like that. He never really cooked much, and we ended up getting live-in help for him. He decided to do that, sort of reconfigure the apartment and do that. And for driving and for cooking and for things like that. He had to give up the things he most liked, like playing tournament bridge, because of his eyesight. He still went to Florida every winter, and some years after my mom died, he met a lady, and she was 88 to his 97, I think, at the time, and they formed a new relationship. She came from Montreal, he came from Ottawa, they met in Florida, and she was with him when he died. He died in Florida. He would have these gag episodes, and the question is, whenever I would see my father, I would think, what if he was in a nursing home? What if he broke his hip while he was dancing? Would his whole life change? Would he not be up to watch the night news? Would he not be able to eat what he wanted? And if anybody ever caught him with the gagging, they would say, one strike and you're out. Your liquids would have to be thickened, and your solids would have to be mashed. And how do you thicken a rye and water, which he liked to drink every day at 5 o'clock? and would he get it anyway? And this is one of the reasons why I'm so interested in the safety autonomy issue that I'm going to talk about without slides in a very informal way. So we have him living vigorously, and going to Florida every year and dying in Florida of a massive coronary event, and then all systems went. But in between, this kidney failure we worried about, when that was identified around 96, 202 did I say? When that was identified, they wanted him to close off his trip to Florida, consider dialysis right away. And then somebody actually looked into his record. My husband called up and tried to slow that down, because that would have really hurt my father's lifestyle. He was very vigorous, he had no symptoms. And they looked up some old records, and he had the same kidney values the year before and the year before. Nobody had paid attention to it, but he seemed to be stabilized at the 96% of his kidney function, so why do all that, So he kept going to a clinic about 3 times a year. They would check all his, all the minerals and vitamins and so on, and all the markers, and he never did need the dialysis. One year somebody called me up and said that he was in denial, because he said he didn't. They'd call me up long distance. Your father seems to be in denial. He doesn't want to take the dialysis workshop. He says he'll face it when he comes to it, and well, it turned out to be all right. And the other thing I learned from him was how tricky it is to arrange services at home. And we went with his decision making. We went the route of putting an ad in the paper and trying to find someone to help, not to use any agencies whatsoever. And we did, and the first person we found, my dad liked very, very much, but it did turn out to be a near disaster, because she did have a bit of a drinking problem that we didn't understand. You laugh, but you should have seen us when she wound up. She was driving my father's car to pick him up at this summer place. She had a long weekend, and to give her some relief, and that's when she drank. And so she came in. She came with his car to pick him up at our cottage, very late. By that time, my brother had driven him back home, and my nephew guided her back to the road, and then she was picked up by the cops, and she was thrown in jail. She didn't have any ID. My father was more worried about her than anything else, but fortunately he wasn't in the car when she smashed it into some other cars in a parking lot. So that was a near disaster, but it wasn't a disaster. And then the next person we found was that gentleman who my father already knew, and that worked very well, pretty well. He would drive to Florida with my father's stuff. He was there for 2 years. He was the matchmaker for my dad's girlfriend the second year. But somewhere along the line, Homeland Security wouldn't let him go back into the States anymore. He's a Canadian citizen born in Hong Kong and living in Canada for about 44 years at the time. And so then we suddenly had to find help in Florida, and we went the same informal route and found a wonderful lady from Jamaica who my brother happened to see in the laundry room of the condo my father was renting. And I mean, we really went that route, and it was different. We kept avoiding any advice that Dad should move to a safer setting, and I think that was right. He didn't want to. I am sorry he never got formal vision rehab. And later, some friends of mine who work on that area at the Lighthouse in New York said, would you let someone with a stroke not have stroke rehab? How could you not have let him get, organized it? He did manage to improvise. He would measure the keyhole and the key and find the right things and find people to put in his hearing aid batteries, but it would have helped if he had done that. Turned out he had a few things we missed. He ended up he had both aortic and mitral valve stenosis, and I don't know how long he had that. In the last 6 years of his life, we were worried because he'd have these episodes of getting tired, having to sit down. Once he fell and briefly lost consciousness. So in October of that year, I came to Ottawa. I went to both his kidney appointment and his GP appointment, and we tried to check it out, and they couldn't see anything that caused that. Later, the doctor, when he died in Florida, said, "Well, he didn't have a what am I trying to think of? The kind of MRI that would have shown the functioning." He didn't have it anyway. He just didn't have that particular test, and so that was missed. It might not have made any difference. So I keep them in my mind, and I try to remember all the many things I've learned about them. Mainly that they were Aunt Pearl and Uncle Max, and they were the head of the family, and all these chronic diseases notwithstanding. So long-term supportive services, long-term care. That's care over a sustained period for people who have some measurable loss in function and loss in self-care abilities and who need assistance with daily living. That's your classic definition. I've been using it for 25 years, so I'm going to stick to it. The goals of long-term care are both therapeutic, to try to improve functioning when you can, but then they're also to provide services for unmet needs so that people can live as meaningfully and as possible and participate in society as much as possible despite whatever their disabilities are. Now, I think we have learned a ton in aging and in geriatrics from paying attention to younger people with disability. And I don't know if you're doing that in Montana, whether you have that network to interact with. One of the things I've learned over the last 15 years, and I might not have a chance to show it, so I'll just say it right now. Young leaders for younger people with disability have a different model for thinking about long-term support services and long-term care. Long-term support service is the term they prefer. Caring seems too emotional for them. And more to that model of the disability. And we're helped by the fact that so many of the leaders in the disability world are themselves hitting 65, 70. They tend to be people with paraplegia or quadriplegia, and they certainly don't want to accept a whole diminished view of services because they've hit 65, because they've been living a different way up to 65. I think about long-term care as having three kinds of needs. One is a place to live, a place that's your home, that you could call home and consider home. And then there's a set of personal care and routine services. Some of them could be scheduled and some not. It's hard to schedule general oversight if that's what a person needs, but you can schedule a lot of things. And then besides that, there's the health care, the primary care, whether it's delivered by primary care physicians or nurse practitioners, advanced care nurses. There's the acute care, there's rehab, there's all the chronic disease management, There's everything else that you might have to think about, like mental health services if they were necessary, dental services, and so on. So it's housing, it's the personal care, and the routine. I put routine nursing services under that, things like getting your medications when you need them and so on. And then there's other, I have another diagram that maybe shows this better. If you think about long-term care programs and settings, so you have a residential environment. I have this is supposed to be a three-legged stool if you really don't know how to draw, which I don't. So you have the residential environment, and there's two prongs on this stool. The private space that's your own and the public space. If you're living in your own home, I guess the public space is the neighborhood, or if you're in an apartment building, the shared space. If you're living in assisted living or nursing homes, there's your private space, and nursing homes, unfortunately, it tends not to be very private, and then the shared space. And so getting both of those to meet residential hallmarks is an important thing. Then we have the service capacity, and there we have the routine, ADL assistance, et cetera, and the routine nursing services, and then the more specialized things that you would have to bring to bear occasionally. You wouldn't want to have a whole team that had, 12 different species of healthcare professionals on retainer. It would be too expensive. You would get them as you need them. Then the philosophy is control over your care and control over your life in wherever you're living. So long-term care is really challenging because there's multiple goals. You have to worry about the technical quality of the services, and then you have to wonder if the services are enhancing the beneficiary or the consumer or the patient's quality of life. It's hard to get the right noun here. Sometimes we say participants, sometimes we say recipient. Older people get involved in defining quality when it comes to the aspects of things that are done in their home, how it's cleaned, how the food is prepared, how their life is organized. My father had very definite views. So did my mother, dementia notwithstanding. There's question, and family efforts contribute to quality of care at home, care in assisted living also, because a lot depends on family, and then you have to worry about whether families are making sacrifices. So it's a complicated thing to look at quality in long-term care. Now, talking about quality of life briefly, was my next plank. I think it's helpful to think about what older consumers, older long-term care users want. And most of this, it's sort of verified by research, to live in their own homes, to participate with their family and community, to have meaningful activity, to be treated with dignity and respect, but they also want their health problems to be accurately diagnosed, noticed at the right time, and treated properly. They definitely want control over pain, because you know how acute pain, imagine yourself with the worst toothache you ever had, and then your whole quality of life is resolved around, can I fix that toothache? And so pain has to get under control. Financial well-being is part of quality of life for older people. People want to have their sense of identity and that their life story makes sense, and they don't want to be a burden on other people. And I don't believe that older people distinguish a lot between what's social care and what's health care, the medical model, the social model. They look at it all together. And family members want, if it's their parents or their uncle, their aunt, whatever, they want them to be happy and comfortable. They do want them to be safe. That's a big emphasis. Older people, when they talk about safety, and I've done a lot of focus groups and questionnaire studies, they're not talking about safety like having a fall. Gosh, maybe I have to be tied down. I've never heard anyone request physical restraints for themselves. Family members sometimes request them. But they are talking about safety like in their neighborhood, and is it going to be safe? Is their house going to be safe? Are the people who are going to come into their homes be trustworthy? That kind of safety is a big deal. And family members, of course, want to feel they've done the best they can. It's very anguishing for family members to put people into nursing homes. We got involved in a big study to measure quality of life for